No, it is
There are no
115.
financial disclosures.
115.
Aniridia is classically an autosomal dominant disease due to PAX6, and it's a panocular disorder. It's not just an anterior segment dysgenesis. This is one of the spectrum in which everything can be affected: the iris, cornea, trabecular meshwork leading to glaucoma, the lens leading to cataract and lens subluxation, like here, and foveal hypoplasia and optic nerve coloboma and hypoplasia as well. So everything because of the PAX6 can be deranged. The pathogenesis is a complex interaction of the surface ectoderm, the neuroectoderm, as well as neural crest. So all three layers are affected. The ectodermal theory says that there's failure in the optic vesicle rim development between 12th and 14 weeks of gestation. So this is what causes aniridia with other ectodermal defects. Anomalies in the retina, absence of fovea, absence of iris musculature is because of ectodermal. The mesodermal theory says it's because of inadequate migration or proliferation of mesenchymal elements during the second month, and these are the aniridias with hypoplastic discs. Whereas Beauchamp et al. Actually said aniridia is explained in part on the basis of excessive remodeling and cell death. So if they're deranged, some are hyperplastic and some are hypo. The phenotypes, it's important to understand, are isolated aniridia without systemic involvement. That's the ones that come to us usually. The variant is in the PAX6 gene on chromosome 11p13 or a deletion. They could be autosomal dominant, two-thirds of cases, or a sporadic form in one-third. So the parents could be completely normal. There's, of course, the Wilms tumor, aniridia, genitourinary abnormalities, and mental retardation, the Wagner syndrome, where are larger deletions affecting the adjacent WT1 gene. So WT1 is sitting very close to the PAX6, and therefore, if it is in that region, the WT1, which is the Wilms tumor gene, and the PAX6 may be deficient together. Then, of course, there's one more. There's Gillespie syndrome, which is associated with cerebral ataxia and intellectual disability. There's circumpupillary aplasia leading to a fixed dilated pupil, and that is pathognomical for the Gillespie syndrome. So, the genetic basis, the pathological allelic variant, you have 300 PAX6 mutations so far, which have been described. And the aniridia phenotype may be a result of all these kind of mutations in the PAX6 gene itself. So, it's not enough just knowing that there's a variant in the gene. What the variant is will also decide on what your phenotype is going to be. So, this is what I was saying, the PAX6 and the WT1 very, very close to each other on the 11p chromosome. So, if there is a variant, if there's a large enough variant, it might involve both of them together. I'll just get you through some clinical challenges that we see. This is case one. This 5-year-old boy comes to us with diminution of vision since childhood. The birth history was normal. And the family history, they said there are similar complaints in the family. So he has nystagmus, but the ultrasound of the abdomen has no neuroblastoma. So, sorry, nephroblastoma. So these are what he's like. He's 6'12, he's 15 and 18, so the corneas are all right. Corneal thickness is fine, the cornea is clear, but he has rudimentary iris, stretched zonules. The lens is subluxated superiorly, he has a pannus inferiorly, and he has inferior conjunctivalization of the cornea. But he also has no fovea on the red free, and the OCT is a little weird because there's nystagmus, remember. So this is a moving image, but we still manage to image the fovea, and you see there's no foveal contour at all. So there's complete foveal hypoplasia as well. Then we call in the family and we realize there's a mother, two brothers, and a sister are all affected similarly. So all of them had identical phenotypes, only the father was normal. So this autosomal dominant, just the mother having the PAX6 variant can have the variant in the entire family. We did an exome sequence of the proband of the boy that came to us. Sure enough, it was PAX6 heterozygous aniridia 1 autosomal dominant. So there was no question that the entire family would have had the same. And of course, the first thing you say is please stop producing more children because all your children are going to have this. They kept having these children hoping that the next one would be normal and the next one would be normal. So if on hindsight we had done a proband analysis on the first kid, the counseling would have been do not have any more children because you're going to land up with now the whole family has a visually impaired problem. Case 2 is a 3-week-old preterm baby. This is at 28 weeks, bilateral hazy cornea since birth. There's no ROP, systemically normal, and no history of glaucoma in the family. So, sporadic newborn PCG, and the pressures on EUA were 26 on just brinzolamide. CCT was 800 and 853, very, very severe corneal thickness. 9 and 9.5 millimeters horizontal corneal diameter at a 30-week preterm. Epithelial edema, corneal clarity, grade 3. Also, CEU, no no iris really visible, but the lens edge is visible with limbal stretching. So congenital ectropion UVA we thought, but also a lot of iris stretching, and you can see that the lens is visible. So on table, it was made a diagnosis of aniridia because we realized that it wasn't just PCG. Both eyes had a very high iris insertion, very few processes, zero point 0.7 and zero point 0.8 cup discs. Post-op, the cornea cleared, and then we could image him on the slit lamp better, and you can see the lens edge, you can see the stumps of the iris, and we thought, okay. But surprisingly, he had no nystagmus, his vision was fine, pressures controlled, and we thought we were fine. We've also started doing a flying baby ASOCT courtesy Savleen in our department. So we all do flying baby OCT for our babies as well. So you could see the stumps of the iris and the lens is fine, and we thought it's okay, and the cornea is of course clear. So we did a clinical exam finally, and to our horror, it was a FOXC1. And now you have a FOXC1 complete gene deletion, which is a very, very severe FOXC1. And then we say, are we looking at Axenfeld? I mean, what are we doing? Now we reviewed the child again and retrospectively noticed, sure enough, telecanthus, flat nasal bridge, micronathia, delayed dentition, umbilical hernia, redundant periumbilical skin. And we missed all of this. We didn't look at any of them because we saw ophthalmos, we saw absence of iris, we saw newborn, and we said, okay, so this is aniridia. So aniridia is just absence of iris, but it can't be a disease, and that's one thing that these are slowly things that we are understanding and retrospectively looking at our mistakes and realizing how wrong we were. So this is now we call it an aniridia variant of Axenfeld, and we write it on our charts. Axenfeld aniridia variant, and we have things like that. Okay, so this is a case 2. This is actually case 3. This is a 2-month-old baby, again, cloudy cornea since birth, intense epiphora, photophobia. And under the microscope, this is what it is. So, garden variety, Axenfeld, you can see stumps of the iris, you can see the lens edge, you can see. So, obviously, again, aniridia, grade 4 corneal clarity. Cup disc ratio, again, 0.7, 0.8. Absolute glaucoma, have to be operated, bilateral combined trab with track, 6 months, again an IOP rise, again an axial length increase, so bilateral limited DLCP done at 6 months. Then by the time we get a clinical exam, and to our horror now this time it's CYP1B1. Now we ourselves, and this is the Sangers which I was talking about. So this is a clinical exam sequencing that you'll get. And once you get this, you need to go in, take this variant, and they'll run a PCR through it. And this is a Sanger sequence which will validate the fact that this is exactly it. Now this is R390H, arginine at position 390 being replaced by histidine. We ourselves have looked at something called neonatal onset congenital ectropion UVA as a severe variant of newborn glaucoma. And we've reported that it's not the same as primary congenital glaucoma because it's not trabecular dysgenesis alone, but it's also congenital ectropion UVA and iris hypoplasia occurring at birth. And these were all children who were less than 1 month of age at presentation. We went a step further then, took all these children and did a clinical exam sequencing. 90% of them had arginine 390 histidine. So R390H to my resident now is, ma'am, this is really, really bad. It's a very, very poor prognosticator. And this is what we missed. We missed congenital ectropion UVA in us, in our center, the people who had described it in the first place. Why? Because the iris was so hypoplastic that we thought it was aniridia. 10 months follow-up, corneal edema cleared, the scar remains. This is typical of a CYP1B1 cytopathy. This is what Ken Nischel has now described. CYP1B1 cytopathy is pathognomonic, that the cornea is going to scar, but the edema is going to clear. And this is what happens. So he turns out to be neonatal onset CEO with severe iris hypoplasia, clearly visualized on this EUA once the cornea has cleared. Now you can see the ectropion UVA beautifully. So this is the ectropion UVA, and the iris is so hypoplastic that the actually ciliary process are seen. This is not aniridia. So the good thing about this is there's going to be no limbal stem cell deficiency. There's going to be no foveal hypoplasia if you can take care. And we don't need an optical iridectomy in this child because there is no iris, and this part of the cornea and the lens are completely clear. There's no cataract, there's no subluxation, there's nothing. You just need to give him refractive correction, amblyopia therapy. This kid is going to see. So other genes in aniridia-like phenotypes are, like we've seen, is FOXY1 and PITX2 cause Axenfeld, but aniridia-like Axenfeld. PITX3 mutations most often cause anterior segment dysgenesis with cataract. So if you have a cataract with aniridia, look for PITX3. CYP1B1 mutations can result in severe iris hypoplasia, like I showed you. It may present as aniridia, but it's not aniridia. The disease is completely different. So to conclude, I'm now understanding that aniridia is not absence of iris. Classic aniridia is PAX6 related and a panocular disorder. And that's the aniridia that our textbooks and we've grown up with. But other phenotypes may present with an absence or a hypoplasia of the iris, and there are implications of associated abnormalities of different diseases which we need to. That's what I was talking about. Deep phenotyping is what is important. Thank you. And frankly, the more you learn, the less and less you know. That's something which I've understood. Thank you.
Excellent talk, Sushmita.